Hi everyone, this is Dr. Bonarigo, and we're going to be discussing diabetes and its musculoskeletal manifestations and complications. So according to the American Diabetes Association, diabetes has affected around 17 million Americans with only 11 million diagnosed. Complications are more likely in those with type 1 diabetes than type 2 diabetes. And this is important because, as you know, the majority of the patients that we see are diabetic, and it's important to be aware of the many ways that diabetes can manifest itself in the patient's musculoskeletal system. These manifestations are believed to be as a result of vascular ischemia that's caused by microangiopathy of dermal and subcutaneous vessels, which causes fibrosis of connective tissue. The increased non-enzymatic glycosylation of collagen secondary to hyperglycemia contributes to the development of these musculoskeletal conditions. Neuropathic changes may also be involved. You'll see joint contractures linked with delayed nerve conduction and intrinsic muscle wasting. So throughout this discussion, we're going to particularly highlight the various areas that are affected by diabetes throughout the body. Commonly, we'll see adhesive capsulitis in the shoulder, limited joint mobility syndrome, stenosing flexor tenosynovitis, Dupuytren's contracture, and carpal tunnel syndrome in the hands. We're going to discuss muscle infarction and proximal diabetic neuropathy, also known as amyotrophy in the muscle, osteoarthritis, and diffuse idiopathic skeletal hyperostosis in the bone. And in our arena, we're going to discuss Charcot arthropathy, neuropathic arthropathy, and specifically focusing on how to differentiate osteomyelitis from Charcot when we're talking about the feet. So this table just highlights the comparison of these musculoskeletal disorders between diabetics and non-diabetic patients. So they are all more prevalent in patients that have diabetes, and the most common disorder is going to be the Dupuytren's contracture, which ranges from 20 to 63% prevalence in diabetes versus 13 in non-diabetics. So we begin by speaking about the shoulder, which is where diabetes can manifest as adhesive capsulitis. This is also known as frozen shoulder. It's seen in about 20 to 30% of diabetic patients. It's a condition of varying severity characterized by the gradual development of global limitation of active and passive shoulder motion with an absence of radiographic findings other than osteopenia. The etiology is not well understood. There's thickening contraction of the glenohumeral joint capsule and the collagenous tissue surrounding the joint, which causes reduced joint volume. It is associated with age, diabetes duration, and poor glycemic control in some studies. And as you can see here, there is inflammation and thickening of the shoulder capsule. Adhesive capsulitis is typically diagnosed when the patient is demonstrating reduced range of motion of the glenohumeral joint that is not due to other painful conditions. So an X-ray is useful to rule out other differential diagnoses, but it's not necessarily useful to show that a patient has adhesive capsulitis. These patients are treated with shoulder rest combined with gentle range of motion exercises and physical therapy. Analgesics and or intra-articular injections can be helpful. If not, there's surgical arthroscopic releases for adhesive capsulitis. However, studies are showing that the results of the surgery may not be as good as those seen in non-diabetics when it's done on a diabetic patient. Limited joint mobility syndrome is going to be seen in the hands. It's also known as diabetic stiff hand syndrome or chiroarthropathy. Its prevalence is 38 to 58% of type 1 diabetic patients and 45 to 76% of type 2 diabetic patients. It is associated with increased glycosylation of collagen fibers and deposition of abnormal collagen in connective tissue around the joints. It's a painless non-inflammatory limitation, most marked in the small joints of the hands, although other joints, including the shoulders, feet, and ankles, can be affected. The risk increases with increasing glycated hemoglobin values and the duration of diabetes, but it can be present early in disease as well. So the patients with limited joint mobility syndrome are going to have thick, tight, waxy skin over the dorsal aspect of their hands and fingers. The skin changes superficially resemble those in diabetic scleroderma. That's that diabetic thick skin disease we had mentioned in the dermatologic manifestations and complications lecture. These patients are going to have limited joint range of motion. It involves all the fingers except the thumb. These patients come in when stiffness and contractures lead to decreased grip strength, declining ability to do fine movements, and they have difficulties with their hand function in general. So to diagnose limited joint mobility, you will ask these patients to perform the prayer sign test and tabletop test. So you're going to ask the patients to put their hands together as if they were to say a prayer. And this is a clinical exam for joint mobility. The examination of the hands may show contractures of the proximal, distal, IP, and MCP joints. It's shown clinically by the inability of the two palms to come completely together with the wrist maximally flexed, as demonstrated in this picture here to the left. These patients will also perform the tabletop sign, and they will be unable to make contact between the palmar surface of the fingers and the tabletop, and that's called the tabletop sign seen in this picture. Treatment for limited joint mobility is difficult. Glycemic control should be optimized, but this is a theoretical idea more so than a practical benefit. Physiotherapy with passive palmar stretching and occupational therapy may improve function. So important to know, in contrast to the general irreversibility of limited joint mobility, there are other diabetic hand problems such as Dupuytren's contracture, carpal tunnel, and stenosing flexor tenosynovitis that can coexist with it, are potentially treatable. Dupuytren's contracture, seen here in the photo to the right, is a thickening, shortening, and fibrosis of the palmar fascia. Nodules may be observed on the palms of affected patients. You're going to see flexion contractures of the fingers. The fourth and fifth finger are more commonly affected. The third finger is less likely to be affected, and the index finger and thumb are typically spared. It's bilateral in 45% of the cases, and the prevalence increases with age and the duration of the diabetes. Dupuytren's contractures are not unique to diabetes, but prevalence in diabetic outpatient patients ranges from 16 to 42%. Prevalence increases with disease duration. The contractures are generally milder in diabetics than in non-diabetics. Pathogenesis is similar to chiroarthropathy, and it may exist with limited joint mobility syndrome, occasionally associated with a plantar fibroma. Dupuytren's contracture is treated with physical therapy and hand exercises, and they're beneficial for earlier mild cases. Steroid injections can be useful, as well as needling, enzyme injection, but surgical intervention may be necessary for more severe cases. And you can see nodules and pitting in the hand. Stenosing flexor tenosynovitis is also known as trigger finger. It's reported in 20% of patients with type 1 or 2 diabetes aged 19 to 62. The prevalence of trigger finger is related to the duration of diabetes, but not to metabolic control. Same pathogenesis is seen for stenosing flexor tenosynovitis as diabetic chiroarthropathy. The patients may complain of catching sensation on flexion of their finger. It may or may not be painful, but there's usually a palpable nodule at the base of the affected finger along the flexor tendon sheath, as seen in the image here to the right in stenosing flexor tenosynovitis. It's caused by a fibrous tissue proliferation in the tendon sheath, limiting the normal movement of the tendon. And this is going to be the generalized appearance of the finger as if the hand were pulling a trigger on a gun. Locking may be reproduced on exam with active or passive flexion. Stenosing flexor tenosynovitis is treated with a splint or buddy taping for 4 to 6 weeks. NSAIDs and physical therapy are useful, as well as steroid injections. However, if the patient fails injection therapy, surgical intervention should be considered, and surgery involves a complete longitudinal incision along the thick and fibrous tendon sheath to relieve the constriction. Next, another musculoskeletal manifestation in the hand of diabetics is carpal tunnel syndrome. This disorder is typically characterized by hand pain and paresthesia, sometimes with weakness. It's caused by compression of the median nerve between the carpal ligament and other structures within the carpal tunnel. Carpal tunnel syndrome is observed in up to 20% of diabetic patients. The prevalence of carpal tunnel syndrome in diabetics is associated with diabetes duration, but not with metabolic control. And here we see the transverse carpal ligament compressing the median nerve, the thumb, pointer, middle, and half of the index finger are affected. So again, symptoms are due to compression of the median nerve, diabetic neuropathy, or combination of both. The paresthesia over the median nerve shares the cutaneous distribution of the thumb, index, middle, and lateral half of the ring finger. Pain that these patients will complain of is worse at night and worse with activities involving wrist flexion and extension. Motor weakness can occur due to median nerve entrapment. Diagnosis of carpal tunnel syndrome is a clinical one based on the patient's history along with physical exam findings. Carpal tunnel syndrome can be treated with simple analgesics, volar wrist splints, local steroid injections, and surgical release of the transverse carpal ligament. The next condition that we're going to discuss is diabetic muscle infarction, focusing in on when diabetes can manifest itself in the muscle. This is also known as diabetic myonecrosis. It's a spontaneous ischemic necrosis of skeletal muscle unrelated to atheroembolism or occlusion of major arteries. The pathogenesis is uncertain but appears related to vasculopathic changes associated with long-standing and poorly controlled diabetes. The incidence is rare and it occurs in both type 1 and type 2 diabetics. And the majority of patients have other multiple microvascular complications, including retinopathy, nephropathy, and/or neuropathy. Diabetic muscle infarction will affect patients acutely, so they'll acutely complain of pain and have swelling that evolves over days or weeks. The swelling may be mildly to extremely tender. These patients do not have a history of trauma, and the most common affected area is the thigh, followed by the posterior thigh or calf, and 8% are bilateral. So the image here to the right is just showing the distribution and the percentage of the body parts that are affected by muscle infarction. Most commonly, these patients are affected in the anterior thigh 55% of the time. The posterior thigh and calf is followed at 15%, and less than that, you see the upper extremity, anteriorly, followed by the posterior upper extremity and the lower anterior leg. Diabetic muscle infarction can be diagnosed with an elevated creatinine kinase, leukocytosis. MRI with IV contrast enhancement appears to be useful in diagnosing. A muscle biopsy is definitive but not required. It's only necessary when the diagnosis remains in doubt, despite careful clinical assessment, lab tests, and appropriate imaging. Treatment it involves just symptomatic management with rest, optimizing glycemic control, analgesia, and low-dose aspirin. Next, when it comes to diabetic manifestations in muscle, we're going to talk about proximal diabetic neuropathy, also known as amyotrophy, and it's also known as lumbosacral radiculoplexus neuropathy. Diabetic neuropathy, this is a diabetic neuropathy that's characterized by painful muscle wasting and weakness, most commonly seen in older men with type 2 diabetes. The exact cause is unknown. It has an abrupt onset and affects the lower limbs, typically asymmetrically. It is most prominent in the thighs and buttocks, and these patients typically have pain in the back or the thighs, and these patients will have a loss of the knee reflex on the affected side, as well as a loss of the Achilles reflex. This condition is reversible, so typically these patients will have this muscle wasting, but it'll eventually go away. You can also treat with controlling blood sugar levels, bracing, physical therapy, and analgesics may help reduce the pain. When diabetes manifests in the bone, we have to talk about osteoarthritis. So diabetes may adversely affect cartilage, increasing the vulnerability to the development of osteoarthritis. There is evidence, including at least 2 meta-analyses supporting this association, particularly for type 2 diabetes, and there is less data regarding type 1 diabetes. Some studies, but not all, this is important to note, have controlled for obesity, which is shown to be obviously an important confounding variable in some of these analyses. So osteoarthritis is extremely popular in our patient population, but just keep in the back of your mind when it comes to diabetics, there may be an association there. Next, another disease of diabetes that manifests in the bone is called diffuse idiopathic skeletal hyperostosis. It's also known as DISH or Forestier disease. It's a non-inflammatory disorder, and it's characterized by calcification and ossification of spinal ligaments and entheses, the regions where tendons and ligaments attach to bone. Peripheral joints and adjacent entheses can also be involved. Pelvis, elbow, and important to us is the heel. So if a patient, a diabetic patient presents with posterior heel pain, you may want to think about this condition called DISH. There's a higher prevalence among diabetic patients. 12 to 80% of patients with DISH have diabetes or impaired glucose tolerance. The mechanism of action that is suggested is that there are growth factors like insulin or insulin-like growth factors that might induce transformation of mesenchymal cells into fibroblasts and osteoblasts. Diffuse idiopathic skeletal hyperostosis, again, the majority of these patients will be asymptomatic. They may complain of neck and back stiffness as the disease progresses, and they can be treated with physical therapy, education, diabetes control, NSAIDs, and analgesics. And here is an image showing, particularly in the spine, the hyperostosis formation of the bone. Next, we're going to talk about Charcot arthropathy or diabetic neuropathic arthropathy, which is seen in the feet. And these images here are characteristic of what it might look like. A red hot swollen foot, typically unilaterally, clinically seen here, as well as joint dislocation seen on x-ray at the Lisfranc joint. So in 1868, Jean-Martin Charcot was the first to describe the arthropathies associated with tabes dorsalis. In 1881, Herbert W. Page described involvement of the small bones and joints of the foot in tabetic arthropathies. And in 1936, Jordan established the association between neurogenic arthropathy of the foot and ankle and diabetes mellitus. This is the reason why it's called Charcot, so I felt it was important to include the history. In terms of epidemiology, Charcot is a progressive, non-infectious, destructive disease of the bones and joints in patients with sensory neuropathy. It's uncommon among the general diabetic population, and its incidence is difficult to determine accurately. There was one study from a specialist diabetic center that reported an incidence of 0.3% per year. The majority of patients that have Charcot have had diabetes for at least 10 years. Diabetic Charcot almost exclusively affects the foot and ankle, and most commonly affects the midfoot. Charcot can be caused by anything that can cause neuropathy: diabetes, alcoholism, syphilis, leprosy, meningomyelocele, spinal cord injury, and syringomyelia. The pathogenesis of Charcot is not well understood. It is believed that sensory and autonomic neuropathy is nearly universally present. Normal blood supply and hyperglycemia is seen, and there are two proposed theories: the neurovascular and neurotraumatic theories. So the neurotraumatic theory, or the German theory, proposes that Charcot arthropathy results from repetitive mechanical trauma from weight bearing on an insensate extremity. This trauma can lead to intercapsular effusions, ligamentous laxity, and joint instability. The absence of protective sensation allows continued loading of the fractured extremity, and a heightened healing response is seen. The neurovascular theory, or the French theory, proposes that Charcot is a sequela of increased peripheral blood flow resulting from autonomic neuropathy. Autonomic neuropathy produces a failure of the normal regulatory mechanisms that control blood flow. It causes arteriovenous shunting and vasodilatation, as well as increases the rate of blood flow to the extremity. We will see increased temperature with redness and dilated dorsal veins, as well as reduced bone mineral density and increased osteoclastic activity. More recent research suggests that Charcot is caused by an unregulated inflammatory process. Essentially, a cytokine called rankle will go unchecked, and it is involved in an increase in osteoclastic activity of the bone. Risk factors for Charcot are diabetic patients associated with advanced sequelae of diabetes, so specifically those people who have been diabetic for over 10 years, patients with sensory neuropathy with an absent protective threshold. So this is important to note on your physical exam. Whenever you're evaluating a diabetic patient, you should be doing your monofilament test, your Ipswich test. Limited joint mobility syndrome is also a risk factor, as well as soft tissue glycosylation and a rigid foot type. Charcot will clinically present acutely as a red hot swollen foot in a diabetic patient. And if this patient has no skin, ulcers, or fever, you are to think Charcot until proven otherwise. There's usually unilateral swelling. Skin temperature of the affected foot is elevated. Pain may or may not be present depending on the presence of nerve damage. Important differentials are infection, including osteomyelitis, cellulitis, septic arthritis, gout, and DVT. Plain radiographs will be your first choice of imaging on the initial evaluation, and they may appear normal in the acute stage of Charcot. So again, here's a clinical image of Charcot. You will see swelling, erythema. You can use dermal thermometry to detect that the affected limb is warmer than the other, as well as radiographic changes. However, you may not always see radiographic changes. For your vascular exam, Due to autonomic neuropathy, you may see bounding pedal pulses. The skin temperature is elevated compared to the contralateral foot, typically between 4 and 10 degrees. They're using the thermometry in the picture. Rubor redness may be seen, as well as anhidrosis with or without xerosis. On your neurological exam, you may see diminished or absent deep tendon reflexes, protective sensation, vibratory sensation, and proprioception. So typically your patient with Charcot is missing all of these. On your orthopedic exam, you'll find joint hypermobility, crepitation, and possible ulceration. As the disease progresses, you may see the longitudinal and transverse arches of the foot collapse, which will result in a deformity with bony prominences, a rocker bottom foot type, which is seen in this image here, as well as loss of calcaneal pitch with relative plantar flexion of the calcaneus. And the picture here on the right is an example of an ulcer that has formed as a result of the Charcot deformity. So radiographic hallmarks, you'll see bony destruction and fragmentation, as you can see in this image here, and this image here as well. Bony remodeling, joint destruction, subluxation, and dislocation. Changes can typically be delayed and have low sensitivity. On X-ray, a term to describe the appearance of Charcot is a bag of bones. It's hard to differentiate where one ends and one begins. An MRI can be useful to detect subtle changes in the early stages of active Charcot when X-rays could still be normal, and this is in the absence of an ulcer. It's helpful to distinguish an abscess from Charcot, but it's not good at differentiating the Charcot from osteomyelitis because both of the conditions look very similar. A bone scan, when it's a combined scan, can be used to detect the presence of superimposed osteomyelitis. So you could get a technetium-99 scan, which is sensitive for active bone pathology, but not specific for osteoarthropathy, and an Indian white white blood cell scan, which has a high specificity for infection to attempt to differentiate osteo from Charcot. So Charcot, the diagnosis is primarily based on the history and clinical findings. Inflammation is the earliest finding and plays a key role in the pathophysiology. The occurrence of acute foot or ankle fractures or dislocations in neuropathic individuals is considered active Charcot foot. This is due to the inflammatory process of bone healing, even in the absence of deformity. X-rays should be the initial imaging. Charcot can be classified based on anatomically where the joints are affected, and this is called Sanders and Freiberg. Class 1 is in the forefoot. Class 2 is the Liz Franks joint, which is going to be the most commonly affected joint at 45%. Class 3 is the mid-tarsal joint, often including the navicular cuneiform joint, which is also pretty common at 35%. Class 4 is the ankle and subtalar joint, and Class 5 includes fractures of the calcaneus. And why is the Liz Franks joint the most common? It's the neuropathy plus the increased forefoot pressure plus the Achilles tendon structural functional pathology and equinus, which causes the midfoot breakdown in these diabetic patients with Charcot. Charcot can also be staged radiographically according to the Eichenholz classification. This is stage 0 through 3. Stage 0 is your clinical or subacute stage. Stage 1 is your developmental acute stage. Stage 2 is your quiescent stage, and your stage 3 is your consolidation or resolution stage. In your Eichenholz stage 0, radiographs are unremarkable in the absence of an acute fracture or dislocation. However, clinically, there's a significant increase in soft tissue volume, and density may be the most impressive finding on the X-ray. And clinically, this is what the foot would appear like here to the right. Eichenholz stage 1, this is also known as the developmental or acute stage. There's hyperemia due to autonomic neuropathy that weakens bones and ligaments. Clinically, there's going to be diffuse swelling, erythema, warmth, minor bone deformity, joint instability, and laxity. And x-rays will show periarticular bone debris, subchondral bone fragmentation, subluxation, dislocation, and fracture deformity, as seen here on the right at the Liz Franks joint. Eichenholz stage 2 is also known as the coalescence stage. Clinically, there's decreased edema, erythema, and warmth. There's now major bone deformity. The joints become less mobile and more stable. And on x-ray, you'll begin to see callus formation, bone sclerosis, fusion of bone fragments, absorption of bone debris, and deformity. Eichenholz stage 3, this is the last stage in the consolidation stage. It's associated with restabilization of the foot with fusion of the involved fragments. Clinically, there's going to be mild to no swelling, no erythema, no warmth, with a fixed bone deformity and joint stiffness. X-ray is going to show rounding and smoothing of bone fragments with decrease in sclerosis, bone consolidation, joint collapse, and deformity. As you can see here, more rounding and smoothing of the bone fragments. I felt like this was a useful table to include, corresponding the Eichenholz stages with treatment. So for a stage 0 Eichenholz, this is when clinically you have an erythematous, edematous foot that is warm to touch. You're going to, you're certain that this is Charcot, you're going to put these patients non-weight bearing in a total contact cast and closely observe them. In the fragmentation stage, Eichenholz 1, these patients should be in a total contact cast and limited weight bearing. In stage 2, these patients can be in a total contact cast followed by a crow walker. And then lastly, in stage 3, this is when you have more of a stable foot. You can consider doing surgery at this point. You can either do just a planing of bony prominences that are associated with the presence of an ulceration, or a reconstructive surgery for obtaining a more stable plantigrade foot. So treatment primary goals are to obtain a stable plantigrade foot, to keep the foot free from ulcerations, and to prevent further fractures and deformities. The selection of the treatment plan is dependent on what phase of Charcot that you're in, the location, severity, and the presence or absence of an ulceration. So you can consider conservative versus surgical treatment. Immobilization at the acute active stage is the most important management strategy. This is very, very important to remember. So total contact casting is what we want to do for that acute phase. This is the gold standard in offloading. It permits offloading while uniformly distributing weight-bearing pressures over the entire foot surface, and more importantly, up the leg to the calf. Guarded ambulation will lower the risk of developing contralateral Charcot with strict non-weight bearing. The advantages of using a total contact cast include forced compliance. It'll shorten the patient's stride length, reduce shear, restrict ankle motion, reduce peak pressures, and it allows ambulation during healing. How does a total contact cast work? It redistributes the pressure from the forefoot to the heel and to the tibia and the calf. Up to 30% of the load is distributed in the cast part, not the foot part. And so here are some images in A. They're putting a stockinette over the foot and they're cutting the crease at the ankle, because that crease at the ankle can sometimes irritate the skin and even cause an ulceration. In B, they're using some felt to well pad bone areas with bony prominences, the tibial tuberosity, anterior aspect of the ankle, and then they're using web roll around the cast to well pad it and to really well pad those bony prominences. Here is an additional felt pad going onto the bottom of the foot, and then a very well padded pad that's going to go around the forefoot, and then they're going to wrap the entire thing with fiberglass. And then here is the end product, your total contact cast that your patient is going to weight bear on. There's also products such as this. This is called the Easy Total Contact Cast. It's a combination roll-on cast and cam locker. These are easy to put on. They're very simple steps that come in a box from a company, and you put the cam walker on in addition to the total contact cast, and these are relatively easy to remove. The total contact cast was reported by the Journal of Prosthetics and Orthotics to have a 65% reduction in forefoot plantar pressures in the cast, with excellent reproducibility of load redistribution, with total contact cast applications that were spaced 1 week apart and applied by the same technician. Journal of Rehab said that decrease in pressure in the first metatarsal head by 69% and in the heel by 45% was obtained with the use of a total contact cast. So total contact casts will allow the patient to rest, and if they elevate, to decrease swelling. The first cast change is typically done at 1 week. Due to a rapid decrease in edema, the cast can loosen, which can then lead to blisters and ulcerations. So it's important to closely monitor these patients that you're serially casting. Follow-up casts are changed at 1 to 2 week intervals until erythema and edema have resolved, temperature of the affected limb has decreased within 2 degrees of the contralateral foot, and stabilization is established on a radiograph. It can be a very long process. It can take up to 6 months. Total contact cast is indicated for non-infected neuropathic foot ulcers, Charcot neuroarthropathy, postoperative care, as well as preulcerative conditions. A total contact cast is contraindicated if a patient has an acute infection, if they have poor vascular status with an ABI of less than 0.8, palpable lymph nodes, known non-compliance, excessive leg or foot swelling and fragile skin, if the patient's foot does not fit into the cast or boot, and if they have a Wagner grade 3 or 4 ulcer. You should not use a total contact cast. After you are done using the cast, conversion from active to coalescence is based on clinical judgment and radiographic evaluation. So you have to take serial x-rays of these patients when they come into your office, and once you see that they're now in the coalescence stage on the radiograph, you can take them out of the cast. You also need to use the dermal thermometry to determine the temperature difference, and if the affected limb is now within 2 degrees of the other side, you can consider transitioning out of the cast as well. Long-term or permanent bracing may be needed. There should be a gradual return to protective weight bearing using Charcot restraint orthotic walker, patellar tendon bearing braces, custom molded shoes, ankle foot orthotic, or something of the sort. There's also what's called a prefabricated pneumatic walking brace. This can be used as an alternative to a total contact cast. It's indicated in patients with severe foot deformity or who are non-compliant, prevents transfer forces to the forefoot during propulsion. The benefits to a prefabricated pneumatic walking brace is that if this patient has a wound, it's easier to keep an eye out on the wound. They're easier to apply. And with this, you are allowed to use various dressing bandages for wound care. Pressure studies show that prefabricated cast walkers are comparable to total contact casts as long as the walkers are non-removable, because the patients could always just take it off. So when you're transitioning your patient out of the total contact cast, a great device for them is your Crow walker, which is called a Charcot resistant orthotic walker. It's a bivalve, fully enclosed ankle foot orthotic with a rocker bottom sole. It can be used in the remodeling stage, and it will distribute pressure equally throughout the foot and the leg. The crow may be an effective alternative for the patient who cannot tolerate a total contact cast due to claustrophobia or a highly exudative wound that requires dressing changes. There's also the patellar tendon-bearing brace, which is used to transfer weight-bearing forces from the orthoses through the patellar tendon, thereby decreasing weight-bearing forces through the foot and ankle. And there are other devices, ankle foot orthoses, diabetic healing shoe with a custom inner sole, and shoe with a rocker sole and modal total contact cast orthoses to offload areas of high pressure. So these are all devices to consider when your patient is ready to be transitioned to a weight-bearing status out of their total contact cast with Charcot. Bisphosphonate therapy is a treatment used for Charcot. The mechanism is to promote osteoclast apoptosis and inhibit osteoclast activity, preventing bone resorption. It's used commonly in diseases characterized by abnormal bone turnover, such as Paget's, osteoporosis, osteolytic bone metastasis, Gorham-Stout disease, and others. It's most commonly used. The most commonly used bisphosphonate is pamidronate or Ardea, and it's a second-generation bisphosphonate. Surgical fixation is also a treatment option for Charcot. It should really only be considered after all conservative measures have been exhausted. It's necessary in cases of continued ulceration, gross instability, the presence of infection, limb shortening, and difficulty in shoe gear. It's indicated when there's instability, deformity, pain, chronic recurrent ulceration, failed conservative treatment, and when there's a high-risk foot. Procedures include exostectomy, arthrodesis, dorsal plantar planing, external fixation, intramedullary rod fixation, and tendo-Achilles lengthening. Rigid deformities cannot be offloaded. There can be a significant plantar or dorsal osseous structural deformity that provides stress focus, and an ulceration will occur. Amputations are indicated when there's been a failed surgery, osteomyelitis, or an unstable arthrodesis procedure. It's your last case scenario in terms of limb salvage in a patient with Charcot. Sometimes ultimately they would benefit from an amputation versus continued surgery. So an important thing everyone needs to understand is how to differentiate Charcot from osteomyelitis. So here's a clinical picture of a patient with Charcot with a rocker bottom foot, with a wound present at the plantar midfoot. And is there a way that you can differentiate this from, is there a way that you can tell that this patient has osteomyelitis or Charcot? And the next step would be to order a radiograph. And here's your radiograph. And on this radiograph, you can see lucency here where my mouse is to suggest the presence of the ulceration plantarly. And then you see this hypertrophic bone formation plantarly. And hypertrophic bone formation can be seen with Charcot and osteomyelitis. So there is no way to know that what we're looking at is one versus the other. Many times, when a patient has been evaluated for a DVT or undergone oral and IV antibiotic therapy for cellulitis, before a clinician obtains an X-ray or MRI that suggests the presence of Charcot arthropathy or osteomyelitis. So it's really important for you as the podiatrist to be able to recognize the possibility for Charcot, the possibility for osteomyelitis, and the need to rule out one versus the other, because other specialists will commonly miss Charcot as an option or as a differential diagnosis. There was a study done that showed 80% of patients with Charcot arthropathy were initially misdiagnosed with gout, DVT, or cellulitis. Patients with Charcot arthropathy may have a history of antecedent trauma, but typically present before ulceration of the foot or ankle. So when you're trying to differentiate osteomyelitis from Charcot, some important history and physical findings that are suggestive of osteomyelitis are these listed below. So the patients typically have a history of presence of local ulceration currently. You may see a sausage toe in a digit that has an infection of osteomyelitis. The patient can be afebrile, and chronic wounds may not show any signs of inflammation, yet osteomyelitis may still be present. The probe to bone test is highly suggestive of osteomyelitis. And you can also perform a dependent Ruber test. So if the erythema in an affected foot and ankle resolves with elevation, think Charcot arthropathy. However, if there's persistence of the erythema with the elevation of the leg, think infection. Hematologic studies suggestive of osteomyelitis. You always want to get your CBC with differential, your ESR-CRP. Remember that an ESR that is substantially elevated over 70 millimeters per hour strongly supports a diagnosis of osteomyelitis and tends to slowly decline with appropriate therapy. Many patients with histologically proven osteomyelitis may be afebrile and have a normal white blood cell count. So using these hematologic studies without other correlating factors may not be a useful tool to aid in differentiating Charcot arthropathy from osteomyelitis. The gold standard, whenever you're considering Charcot versus osteomyelitis, as in those clinical pictures I had showed you earlier, is to perform a bone biopsy. Surgical percutaneous bone biopsy after a 14-day antibiotic-free period represents the gold standard for diagnosis and management of osteomyelitis of the foot. Other studies have shown that an antibiotic holiday of as little as 48 hours is insufficient before a biopsy. You always want to send your bone biopsy for culture and pathology. So performing the bone biopsy will tell you or confirm for you whether osteomyelitis is present within the bone. However, you need to combine this knowledge with your clinical knowledge and appearance of the foot and the patient's history to determine if osteomyelitis is coexisting with Charcot. A new and relevant imaging study known as an FDG PET, or a fluorodeoxyglucose PET scan, is showing promising results in differentiating Charcot from Charcot with osteomyelitis. Unfortunately, we're not anywhere close to being able to use it because it's such an expensive imaging modality. But it's something that is very promising in being able to differentiate Charcot from Charcot with osteomyelitis. So in conclusion, Charcot is a potentially devastating sequela of diabetes. Its treatment requires careful initial management and long-term follow-up. Conservative surgical treatment options can be augmented with the pharmacologic use of bisphosphonate, and surgical intervention should be used as a last resort.